of the uterus, okay? Now this makes it look like it's in the cervix, but it's not in the cervix. It's, again, the uterus is distended, and remember, as the uterus gets distended, that lower segment gets very thin. In some cases, when you see a C-section, you can actually kind of see the baby moving, and it's because that uterus kind of, like the balloon, it just gets bigger and bigger and thinner and thinner. So when they actually cut in the uterus, it just seems like very gentle cuts. So you have the cut in the skin, you have the cut in the uterus, and then they'll push on the fundus to help kind of push the baby out onto the OR table. With a low transverse C-section, again, less risk of rupture. So one of the big questions is VBAC, vaginal birth after cesarean. So let's say the patient, their first delivery was for breech. In that situation, they probably would say, yep, go ahead and try a VBAC. That's different than the situation where the patient either had a small pelvis and had a lot of CPD, so maybe the baby was 7 pounds, 15 ounces, but the baby's head was too big for mom's pelvis. That would be an indication that maybe she has a narrow pelvis, so she's probably not a good candidate then to try and do labor afterwards. So that's just conversation that the patient would have with their healthcare provider. Most of you should get to see a C-section. If not, there's a link here to a video. I think one of the things a lot of students talk about is they had no idea the uterus would actually come out and flip up on top of mom's abdomen. It kind of looks like a melon. And they actually will massage the uterus. But I think after seeing a C-section, it kind of gives you better empathy for women who complain of pain after C-section, because there's a lot of manipulation of organs and structures when you have a C-section. One of the issues for the baby, we want to make sure that the baby gets suction. They often have a harder time getting secretions out. So a baby that's born by C-section is more likely to have crackles in the lungs. And then the other issue is thermal regulation. For both mom and baby, we want to make sure that they keep their temperature normal. So they've changed some protocols in the OR. Those of you who've seen a C-section, did they mention anything about the temperature in the OR? Or did you notice the temperature in the OR?
It was pretty warm compared
Yeah.
to what I thought.
So it used to be in the past that the OR was very cool because you were wearing all that garb, and what we found is that caused complications in moms and babies. So now they've made it very warm, so your surgeons and folks get sweaty, but most of the time you're in the C-section for only maybe about an hour, hopefully maybe a little bit less, but tend to keep it warm because that helps keep mom and baby's temperature stable. So when you have a repeat C-section, one of the concerns about repeat C-sections is, again, any kind of surgery that they may accidentally nick bowel or bladder. So that's one of the reasons why in the recovery room you want to make sure that you assess the urine coming out of the Foley catheter, and you should not see any hematuria at all. Because remember, the catheter's in the bladder, so there's no lochia mixing with the urine in the catheter. That's different than somebody having a vaginal delivery who's voiding, their lochia is mixing with the urine. Okay, so if I see hematuria in a catheter, that would cause me a little concern. I'd want to continue to monitor that and notify the provider about it. The other thing that we're seeing, the more C-sections we're doing, that women actually are having abnormal, what's called placentation. It's a fun word. It's where the placenta abnormally embeds into the uterus. And so we get things called like an accreta, and so we can't separate so with the next baby, the placenta will not detach. So like an abruption means it comes away too quickly, like before it's supposed to. In an accreta, it kind of grows together and we can't separate it. Well, the patient will hemorrhage, and so then if we can't get the placenta separated, we have to take the whole uterus out. She gets a hysterectomy and her childbearing is over with. So that's a concern. Obviously, patients who have C-sections are going to be in the hospital longer. We're concerned about SSI, surgical site infection. There's a lot of safety issues. Thankfully, at least recently, no sponges or instruments left in anyone. About 5 years ago, we were at clinical where that happened. And again, it's like, how in the world does that happen? Because you have many people do counts. It's because they're counting the numbers, but they're not paying attention to what they're counting. They're going through the motions. So I would take all of that activity very seriously and just take the extra 60 to 90 seconds to slow down to make sure everybody is counting. And often the circulator is also responsible if something's not right to go back and double check. And then I mentioned hysterectomy. So hysterectomy is a removal of the uterus. So I apologize, the water fountain is broken, so I've had to get hard candy to keep my voice, so I sound like I'm talking with food in my mouth. I am. This is an example of a concept map with failure to progress. So you can see in this situation, the patient, vital signs were fine, cervix was 2, 70% -2, membranes were ruptured for meconium stained fluid for 19 hours. Fetal heart rate's 120, has a reactive non-stress test, so the baby's not in distress at all. She is having contractions. In looking at what nursing diagnoses would be appropriate for this patient in terms of trying to labor, pain with contractions, risk for injuries, and so this TOLAC, and that's what sometimes you'll hear the nurses say, a TOLAC is a trial of labor after cesarean. It is the same thing as VBAC, which is vaginal birth after cesarean. So why the difference in vocabulary? It's because one is you are trying to labor, we aren't sure what the outcome is. VBAC is often you were successful, but it's kind of the same thing. Anxiety and then risk for infection. So if you're having difficulty coming up with nursing diagnoses for your patients in labor and delivery, it's some of these very basic common things. I mean, you could probably argue that all moms and babies have risk of infection. So if you have data that supports that, so I would have things like being GBS positive, depending on how long her water's been broken, what her temps doing, what the baby's baseline's doing, what's her white blood cell count, does she have a history of exposure to sexually transmitted infections? That kind of data would support risk for infection. If I'm really focused on pain for my patient, that's a priority for my patient. And I think, again, in labor and delivery, what you'll see is something's a priority at 8 o'clock, it's resolved by 8:30. So then when you're trying to do your paperwork, it's like, well, that was a priority, but we got it kind of resolved at 8:30. So that's where you need to have good conversation with your clinical instructor, because things happen and change so quickly. If you have a patient who delivers vaginally, her priorities when you leave for the day are very different than when you started. So taking care of your patient in a C-section. So how many folks have been in recovery with a C-section patient? 1, 2, 3, 4, 5. Did you all check the fundus? Yes. Did you check it every 15? Okay, good. One of our clinical sites, I don't know who it was, the provider said, don't check the fundus because it hurts the patient to, like they did one fundal check immediately in the OR, did one when we got to recovery, but the provider said don't keep doing it, it hurts the patient too much. And for me as a nurse, that raised a huge red flag, because with a C-section, you still are at risk of having a boggy uterus after having a baby, and so you wanna make sure and do those fundal checks every 15 minutes, just like you would in a vaginal delivery. It is more uncomfortable though, because you have an incision. And it's really important whether you have a vag delivery or a C-section that you support that lower uterine segment and you are massaging that fundus. But one of the things I hope you noticed with the C-section, they try to really do a good job of suctioning and cleaning kind of everything out. And that first check, usually back in the OR, they really push pretty firmly because the anesthesia is still on board, and try to get it really nice and firm there in the OR before, because it is really uncomfortable for the patient. In the recovery room, you're gonna be checking a vital sign. She's on a pulse ox and an EKG. You wanna make sure her dressing is dry and intact. If there's any drainage on the dressing, we would note that, and if it's increasing in size, you need to let the surgeon know. If you have a change in level of consciousness, a change in respiratory status, we usually let anesthesia know about that. We want our pain under control. A lot of our patients will get that long extended release morphine, called Duromorph. The whole big thing about Duromorph, it causes a lot of itching, and then we have to be careful about respiratory depression with that. The itching is by far the most common side effect with that particular medication. You'll assess her sensation, and we would want her to hopefully bond and breastfeed with the baby. So ideally, the baby is with her. But you have to realize there are some situations in which she had a C-section, the baby is not able to be in there, maybe the baby had fetal distress, so the baby's in NICU, so she's very concerned and worried about the baby. So some women have never even held their baby yet, and the baby's gone. That's a pretty stressful situation. Sometimes what they'll do is they might try and take mom by NICU or the nursery to see the baby if they can, so she can at least see what's going on, because again, it's kind of like what happened, and all that worry and anxiety, you tend to kind of think the worst,